Okay. Hi, everybody. My name is Jennifer. I am one of the education and outreach specialists here at the Sexual Assault Resource Center. I have a very special guest today. I have Nancy Downing. She's absolutely amazing, and we're really happy to have her here. We're going to be talking about a lot of different things today, mainly just what a SANE is, what a sexual assault forensic exam is, go into some details about that. She is extremely knowledgeable, and we're really happy to have her talk to us today. We are going to be talking about some heavy topics, so if for some reason at any time you feel uncomfortable or something triggers you or just kind of makes you maybe brings you back to a time that you maybe don't want to think about right now, our hotline is open. It's 24 hours, and so you can always call that hotline. We do have free and confidential counseling, so you can call that hotline and get on our wait list. So yeah, I'll let Nancy get started and introduce herself quickly. This is going to be posted on Facebook, so any questions you have, you can just comment them, just so you know that those comments are not confidential. So any confidential comments or questions, please call our hotline as well. So Nancy, I'll give it to you to introduce yourself.
Great, thank you. Howdy. I'm Nancy Downing, and I'm an associate professor in the Center of Excellence in Forensic Nursing at Texas A&M University. I teach in the Forensic Nursing Master's Degree Program, as well as conduct research related to interpersonal violence. I take call right now as a forensic nurse at Baylor Scott & White in College Station. I took call for 2 years as well up in Temple at Baylor Scott & White at both the pediatric and adult hospitals, so I could get some more experience with the full scope of practice across the lifespan. Prior to coming to Texas in 2016, I worked in a forensic nursing program in Iowa City, Iowa for 12 years.
Well, thank you. Yeah, and we also, another thing I didn't mention earlier, part of what SARC does, we do accompaniments to the hospital. So a lot of what we're going to talk about today, there is most of the time an advocate there. Right now it's a little bit different because of COVID-19, but non-pandemic, we are at the hospital with survivors, basically staying with them through the whole process if that's what they need in that moment. Okay, so we'll move on to the next question we have. So what does a SANE exactly specialize in, and what is a sexual assault forensic exam in general, for the audience maybe that doesn't know about it or hasn't heard about those terms yet?
Sure. So first of all, I just want to say, I was telling Jennifer earlier that we miss the advocates accompanying us, or accompanying the patients rather. I feel like it's accompanying us sometimes at the hospital because their role is so important. So we really miss you. And I've never appreciated the role of an advocate more than I do now that you are not there. We still provide your contact information to our patients, and we can't wait for you to get back. So a SANE, or a sexual assault nurse examiner, is a forensic nurse who's an experienced nurse who's also undergone additional education in providing the specialized care that patients who have experienced sexual assault really need. It's evidence-based, it's trauma-informed. SANEs are only one type of forensic nursing, so we also take care of victims who have been exposed to child abuse and neglect, elder abuse or neglect, intimate partner violence or domestic violence, strangulation, attempted or completed homicide, human trafficking, or any other non-accidental trauma. Some forensic nurses also provide care for perpetrators. So what is a sexual assault forensic exam? It's a specialized medical exam that provides comprehensive care to patients after they've experienced sexual assault. So it includes many parts. These exams aren't quick. They often take a few hours. We begin by explaining what is a forensic nurse and what is a medical forensic exam. So we will conduct a patient history. We will get their past medical history. We'll ask them for a history of the assault. We will obtain the reason why we want to get that history. It's really important because we want to understand what risks they were exposed to from a healthcare perspective, from a mental health perspective, as well as to know what treatments to offer them. It can also be really valuable evidence. What they tell a medical provider in the conduct of a medical exam is can be used as an exception to the hearsay rule in legal proceedings. So what they tell us about the history is really important for their medical diagnosis and treatment, but also can have strong evidentiary value. We can also offer them a head-to-toe exam to assess them for injuries and treat those injuries. We can offer them an anogenital exam to identify and treat them for injuries. We can offer them evidence collection. So that is basically, you've probably heard of the kit, the sexual assault evidence collection kit that people talk about. It is really, just to demystify it, is a bunch of swabs in swab wrappers, and those swabs are used to collect evidence from the body. We take those swabs, we put a little moisture on them, we'll rub them on the body gently to pick up any DNA that might be left there from the perpetrator that can be used, again, for evidentiary purposes. So we can collect that evidence. We can offer the medications to prevent unintended pregnancy and sexually transmitted infections, including HIV. And then we provide discharge and follow-up recommendations. It's important to note that all of these things were choices. So the patient is the person that's in control during the exam, and we offer them all these parts of the exam, and we listen very carefully to what parts of the exam they want, and they can change their mind at any time, and we keep them in control. Another important thing to note is that forensic nurses are also educated in trauma-informed care and the neurobiology of trauma, and that means we understand what trauma can do to impact the brain. And so persons who are experiencing an acute traumatic event, which sexual assault is, have special needs for control, for promoting of trust and transparency. We try to empower them through collaborative decision-making, offering them lots of choices and promoting their safety, also considering their cultural, historical, and gender issues. We also like to make sure advocacy services are available to every patient at the time of the medical forensic exam. And all of this is so that we can start those patients on their healing journey as soon as possible.
Thank you. Yeah, and I think the whole part of control and letting them really decide what parts that they want to get done, what evidence collection they want to be collected, all that stuff is really important. And that could be a fear for maybe a survivor who was recently sexually assaulted and they don't know if they want to get the exam done. Some people might have a idea that they have to get everything. If they go in there, they have to get everything done and it's forced upon them. But I do love that it's not, and they get to choose if they maybe want something, maybe they do want pictures or they don't want some evidence collected. So I think that's a really important thing to note for anybody watching or just for future reference as well. Thank you for that. Yeah,
it's also really important that they understand their legal choices too, because my own research that's going to be published soon in the Journal of Interpersonal Violence indicates that a lot of people think that when they come in for a medical forensic exam, that's part of the reporting process. So we know that a majority of the people who come in for the exams do end up reporting to police, but we also know that the majority of people who've been sexually assaulted don't report to police. So we know that means a lot of people are not, unfortunately, coming in to have the medical forensic exams. And we want them to come in primarily because we recognize sexual assault is a health issue. So primarily what we're providing and offering to them is that health care. So even if they don't want to report to law enforcement, we really would encourage them to come in and seek that medical care and treatment. They can also have the evidence collected and it can be sent to as a non-report kit, and they have 5 years in which they can change their mind and go and report to law enforcement. They don't have to make that decision today. So it's also important that they understand all their reporting options too.
Mm-hmm. And you guys do a great job of that. And when we were there, we always talked with that with the survivors as well. So yeah, I think that's great to add too. Okay, so what made you want to become a SANE and enter the field of work that you're in now?
Sure. So that's a great question. Before I was a forensic nurse, I was a nurse on an inpatient medical psychiatric unit. at the University of Iowa. And so it didn't take me long working there to see the interconnectedness between a history of trauma and mental health consequences, sometimes years later. So I had worked there for about 5 years when I learned that my hospital had a sexual assault nurse examiner program. I had not heard of that before, and I was just sitting in a continuing education session, and I heard a SANE speak, and I was completely transfixed. And I thought, this is the coolest thing in the world, because I can use my mental health nursing skills that I've learned to support these people at a really vulnerable time. And I feel like that's something that I'm, ready and prepared to do. I did not necessarily appreciate all the technical aspects, the forensic aspects, and I think a lot of people actually come to it from that perspective. They learn about the forensic piece and they think, oh, that sounds cool and I want to do the forensic piece. Whereas for me, it was really the helping people at a moment of trauma piece that drew me to it. So we all come to it from different journeys. So I really believe, and I still believe, that sexual assault nurse examiners, along with advocates, can make a huge difference in launching people on that journey. So that's another reason why we really want them to come in and receive that specialized care.
Mm-hmm. And that SANEs and advocates, they might be the first people that this survivor is interacting with after the sexual violence that happened to them or sexual assault that happened to them. So yeah, I agree. It's extremely important to have people that are caring and wanting to help this person in every way possible. But yeah, so I know, so SANEs they're specifically for sexual assault, but also domestic violence overlaps a lot. And so could you tell me about what your experience with domestic violence survivors are and some components that are reoccurring for these cases? Also, how can the forensic exam be different for domestic violence survivors as well?
Sure. So that's another excellent question, because when I first started working, it was in a strictly, supposedly sexual assault program. But I think we also learned quickly that there was some overlap there. So we'd have somebody came in for a sexual assault, and we learned that the perpetrator was their intimate partner or a former partner or a dating partner. And so there was that other component there. So when we realized that intersection, we thought the converse might also be true, right? There might be domestic violence survivors who may be underappreciating that maybe there's a sexual abuse component, or maybe we want to go and extend our services to domestic violence survivors because they also have health concerns. They're very similar concerns. A lot of the dynamics are similar. So unfortunately, in my old program at that time, the DV advocacy world and the sexual assault advocacy world were really quite siloed. And I don't think they really appreciated that overlap. So we didn't have a lot of luck initially working with the DV program and helping them see that perhaps our services might be valuable. But we did continue to have patients who would come in to have hospital exams when they had a health concern that was serious enough to warrant that. So that gets to some of the recurring components that we see. So oftentimes patients who are in these relationships where domestic violence is a component aren't presenting out of their own volition. They're presenting either because the police were called, or sometimes it's because their injuries are severe enough that they needed medical attention, and they don't always initially disclose the cause of their injuries. So we're getting better about asking about that, right? And then referring them. So when I examine them, it's rarely ever the first time that they have been injured, physically harmed by their abusers, leaving out the psychological harm that can be equally or more damaging. But some of the common injury types that result in presenting to the hospital include strangulation. They'll typically use the word choking, but we know it as strangulation, and injuries to the head and abdomen. So injuries that are more concerning to them or causing more pain, could have potentially more severe consequences. So often when we examine them, we'll observe older injuries, bruising, other types of injuries to the extremities that they had received but did not come to the hospital for. So another thing we've noticed that if we asked, we sometimes learn that the patient was either forced to have sex or when they didn't want to, or that they felt compelled to have sex with their abuser as a way to try to appease them if they were feeling like things were escalating. So in those cases, we will offer to provide them a sexual assault examination as well. So we're starting to appreciate more those overlaps. It's critical that forensic nurses understand, I think, that patients might not be ready to leave their abusers, and not to judge them for that or even give the appearance of judging them for that choice, because we might not understand that dynamic, but we're being increasingly educated to understand that those dynamics are complex. The forensic exam experience can be different for people who come in with domestic violence related injury than sexual assault outside of a DV relationship for several reasons. First and foremost, the abuser is, by definition, someone with whom they should feel safe, right? Often an intimate partner. So that constant erosion in trust that they're experiencing within those relationship dynamics can result in some behaviors that may be difficult to understand unless a nurse is educated to understand that dynamic. So patients, they might not exhibit gratitude. They might not be there because they chose to be there. They might be feeling threatened, so that could cause them to be defensive or irritable. So lacking this basic trust, they can even seem reluctant or be reluctant to accept treatment sometimes. They often have complicated feelings towards their perpetrators too, right? Toward their abusers. So they aren't necessarily ready to leave the relationship, and that can be hard for nurses who feel drawn to this work because they want to save people or help people. So it's really important for forensic nurses to understand these dynamics. It's part of the trauma-informed care we provide, and not to appear to be judging them for any of their choices.
Mm-hmm. And another thing too with that, sometimes the client or survivor might be living with the abuser. So they might, maybe let's say they get the exam without anybody knowing, they go and get the exam done, but then they go home to the abuser. And I can understand that's probably really hard to see them go back to that person and be living in the house. I think safety is number one, but also it's their choice of what they do and kind of where they go.
Right. So knowing that and understanding that is critically important, that it's important not to assume that they're leaving the relationship, because that can erode their trust. If they think that you're only helping them because you're rescuing them in some way, you don't understand that they may still love their abuser, or they may be afraid to leave them, or they financially can't leave them. There are myriad reasons why they stay in those relationships. And so we shouldn't assume that they're ready to leave that relationship.
Mm-hmm. Exactly. Yeah. I think those are extremely important. And so you did mention strangulation, and I know more recently, I would say, this has been a very big topic, definitely for even me to be researching and looking into, and I know a lot of people have been talking about it more. Why is it so important to acknowledge strangulation in a forensic exam?
Sure. So I would say the most important reason is because that strangulation can be fatal if it's not recognized and not treated. It can have other adverse health consequences as well, because it involves, occluding blood flow to the brain. So when you do that, you could cause traumatic brain injury. And some people are in relationships in which strangulation is a frequent occurrence. And so over time, that occlusion is causing blood vessels in the brain to die, right? So that over time can lead to traumatic brain injuries that will have neurocognitive consequences, such as frequent migraines or headaches, visual disturbances, cognitive disturbances, memory loss, hearing impairment. And if you think about how those things can impact functioning and health-related quality of life, they can cause a lot of adverse consequences, not just health, but also life consequences. Also, death might not occur right away. So you could have somebody who comes in with the strangulation, doesn't report it, we didn't ask, or they do report it and we didn't get the proper diagnostic testing. They could have an injury, they could go home. Swelling doesn't occur right away, but within 48 hours, they could have sufficient swelling that could interfere with breathing. Another thing that can happen is that a dissection of one of the blood vessels in the neck could cause a blood clot. That blood clot could dislodge, could cause a heart attack, a stroke, pulmonary embolism, all of which can be fatal. So there's many, many reasons why strangulation is important to detect, and we didn't always appreciate that. Repeated episodes, again, I said, can be important. We've learned so much more about strangulation in the last 10 years. We've found that when we specifically ask about it, patients endorse it who didn't otherwise mention it. We've also learned to ask about it in sexual assaults, even sexual assaults that don't involve a domestic violence dynamic, because we're finding a higher than expected frequency of strangulation in the context of sexual assault, and sometimes even some strangulation during sex play. And we'd really like to emphasize the potential danger of this and how chronic occlusion of blood flow can cause some long-term adverse problems. So we're not sure if strangulation really has increased or whether it's just that we're better educated about it and are asking more. There is some evidence that strangulation is increasing in domestic violence and sexual assault. So we want to make sure that we are definitely assessing for that every time. Also, how you ask patients is really important. They don't necessarily use the word strangulation, which is something that we try to educate about. And it's fine that patients use the word choking. We'll use what word they use, but we're careful to document that it's strangulation. I think choking, which is really that, occlusion from an internal blockage, it sounds less scary. So I think one reason people use that term is because, and it may be even a defensive mechanism amongst persons who are in domestic violence relationships, that choking doesn't sound as serious as strangulation. And if you use that strangulation word, sometimes it's helpful to help people understand that what is happening to them is potentially serious. So we can do some education there as well. There's also other ways, though, other than that strangulation, that occlusion around the neck from the external pressure can occur. For example, I had a patient one time who told me that her abuser specifically avoided putting pressure around her neck because he didn't want to leave marks that could be used as potential evidence against him. So instead, he used another type of what we call positional asphyxia. So he pinned her arms behind her back and bent her over so far that her chest was excluded and prevented her from breathing until to the point where she passed out. So it's important to also assess for other types of positional asphyxiation, such as kneeling on somebody's chest. I think, unfortunately, historically, recently, we have learned about kneeling on people's chests can also cause that obstruction of airflow and blood flow that can be fatal. So those are also some things that you see in domestic violence relationships.
Mm-hmm. Yeah, I know it seems like strangulation leads to so many different health issues, and that's why it's definitely so important to note to anybody that's watching this that if you feel like that was in a situation that you were in, or you were choked, or there was strangulation present, to get medical help 100%. But yeah, so that's it for those questions. But I do want to ask you, so what is something that you might tell a viewer who is watching this and thinking, I think I might be in an abusive relationship, like what can I do? So what are some words that you would kind of tell them?
Sure. So I'd like them to know that there are trained persons, advocates, forensic nurses, domestic violence experts who are ready to help them, that understand the complex dynamics, that we won't judge them. We understand that they're not always ready to leave their abuser, but if they need help, we can help them. We're available to help them. We are there to help them safety plan, for example. We can treat any injuries, provide them with resources, and we can document their injuries. We can take photographs. We can take a history of an incident, and they don't have to report to law enforcement if they're not ready to do that. But it might give them comfort to know that we have taken that evidence. That evidence will always be there for them in their medical record. If they do make a choice later to report to law enforcement, they can get that evidence. So basically, though, we want them to know that we're there for them. And even during this pandemic, we're open for business, and we will protect them from exposures. It's safe to come in, and that we're there to help them when they're ready.
Awesome. Well, thank you so much, Nancy. I really appreciate you coming on here. So we work so closely with you and all the SANEs, and we just really appreciate all the amazing work that you guys do. And we hope we can get back into the hospital with you guys soon and start going on those accompaniments and everything. But thank you so much. And again, everybody, if you have any questions or comments that you want to keep confidential, please call our hotline. It is 979-731-1000. 24 hours, you can call whenever. But yeah, we really appreciate it. And I hope everybody has a great rest of your week, and I hope everybody stays safe. So thank you so much, everybody.